Hello from Madrid. I'm Alfonso Jurado, one of the staff of the cardiology team, and it's our pleasure to connect for the second week to the medicine program. Here in the Cath Lab, I have as operators Dr. Jiménez Valero and Dr. Moreno, and also choose as scrubbing nurse Ali, Sofia, the anesthesiology team, Dr. Sagra, and the people from Allegra. That is the device we are going to use for this TAVI. So if we are ready, I am going to give the word to Dr. Tebar, who is one of our fellows that is going to present the case. Danny?
Yes, welcome everyone. So we are presenting our first case, an 88-year-old male with hypertension, type 2 diabetes mellitus and atrial fibrillation, treated with rivaroxaban. In the echocardiogram, we observe 31 millimeters, an aortic peak velocity of 4.4 meters per sec, and an aortic valve area of 0.77 centimeters. The STH score is 3%. In the EKG, we see an atrial fibrillation with left anterior fascicular block. The laboratory tests were normal, and the coronary angiography showed a severe lesion in the mid-right coronary artery. The femoral angiography and the CT scan show good caliber vessels without significant lesions. And in the cardiac CT scan, we observe an annulus diameter of 23.5 millimeters with a perimeter of 74 millimeters. The coronary height is 8 millimeters to the left main and 15 millimeters to the right coronary. The total Agaston calcium score is 673. The device chosen is the Allegra 27 millimeters, which is a self-expanding TAVI device. And our plan is to perform a pre-dilation using a 22 millimeters balloon. The access will be femoral guided by vascular echo, and the beam will be used for the transitory pacemaker. We have chosen a collagen-based vascular closure device called MANTA for the biggest artery closure.
Okay, thank you, Danny. So after this presentation, I'm going to leave you with Dr. Moreno and Dr. Jiménez Valero, who is going to present the setup and the things they already have done. Raúl?
Hello, everybody. Thank you for being connected with us. As you can see, we are doing now the angiography to check the view. As you can see, we cannot view now the right coronary sinus. Maybe we have to do another injection more proximally, because sometimes, as you know, it is difficult to. I think. Okay. Okay, here you can see it. This is a frequent situation, so before repeating angiographies, usually it is better to do another angiography more proximal to completely fill the proximal aorta. What we have done up to now is we have punctured we are going to implant the valve through the right artery, right femoral artery. So we have chosen the left femoral artery for contralateral. We are going to show you.
Santi, tienes aquí. Santi.
Okay. Here you can see how we have filmed the iliac femoral are very good for transfemoral approach. Here you can see how Santiago Jiménez Valero has punctured the right femoral artery. We use for protection purposes contralateral wire, 18 wire. We usually use the steel core wire. We have already implanted the transient pacemaker through up to the right ventricle. Sometimes we use the wire that is inserted in the left ventricle, but we have decided to use the pacemaker. In this case, as Daniel Tebar has told you before, the patient has some conduction abnormalities, so we have decided to use the conventional pacemaker. So now Santiago has crossed with a Terumo wire through the left ventricle. We usually don't use this catheter to advance the Safari wire, but we use as an intermediate step. We interchange with 35 conventional wire. We advance the pigtail, as you are going to see now, and then we use the pigtail to advance the Safari wire in this case. As Daniel has told you, we are going to use an Allegra device. The Allegra device was developed by New Vascular Therapy that was acquired lately by Biosensors. So now Biosensors is the company. This valve was launched in the market several years ago. I think it was 5-6 years ago. El pigtail, por favor. And this valve is a self-expandable valve that is retrievable, not completely, but up to 70-80% of the procedure. We are going now to use the right view to check how the Safari wire is going to be placed in the left ventricle.
Raul, you probably can comment the issue of the coronary artery.
Yeah,
because
that's an important point we have been discussing before. As Daniel has told you also, the height, the distance from the aortic annulus to the right ostia is good. I think it's 16 millimeters, but the distance from the aortic annulus to the origin of the left main is only 8 millimeters. But the width of the sinus, aortic sinus, is acceptable, is good. So we think that the risk of compromising the left ventricle is low. Of course, this is always the theory, but as you know, sometimes when you have an occlusion of a coronary artery during a TAVI procedure, it is frequent that the patient didn't have any theoretical risk factor for occlusion, and also there are sometimes patients in which the risk theoretically is high, but you don't have an occlusion. In this case, the distance from the aortic annulus to the origin of the left main was low, but we think that we can do the procedure without protecting the left coronary artery. So as this is a self-expandable valve, usually we perform a balloon dilatation. As in other devices, usually the balloon is 1-2 meters lower in comparison with the aortic annulus. The aortic annulus, I think it was 23.5 more or less. We are going to use a 22 balloon to predilate the aortic valve. So we are now preparing the balloon. Here we have Chus preparing the balloon. She's a very excellent nurse.
We can't see any question from the audience. We are trying to explain all the steps of the procedure. But if you have any questions, please use the Slido app and we can comment it. You can see probably in the angio that the coronary arteries are very calcified, and as Daniel told you, there's some severe disease, but their lesions are not proximal, and the patient has no angina. So we decided it's another debatable thing, but we decided to go for the TAVI and not treat the coronary artery disease. Yeah, we usually, when a patient, as you know, about 40% of the patients undergoing TAVI have also a concomitant coronary artery disease. It's also, we don't have evidence, but we usually treat when we have a proximal or mid segments of the arteries. In this case, as Alfonso says, it was a very severely calcified mid coronary artery. The patient didn't have angina. As you know, the only randomized trial that has been performed
was negative for treating these lesions, but before TAVI, but this study had some important limitations. For example, the study was interrupted with with a lower number of patients that were going to be included.
And every patient is different. For example, in this case, the coronary artery is so calcified. So if you have a complication doing the PCI before the TAVI, probably it's a fatal complication. So if the patient has no angina, probably it is, in our opinion, the best option.
We are going to do the pre-dilatation. As you can see, we have advanced the 22 balloon. Alicia, that is other excellent nurse with us, is going to...
Sube más.
Aquí. Bien, ¿no?
Okay.
Okay, the balloon is still moving, but I think the balloon has been well expanded. I think the balloon valvuloplasty has been successful. I don't know if the attendees that are connected with us are in agreement with us. You can share your opinions, because, of course, many things that we are doing here and that usually the operators do during TAVI procedures are different in different centers. So the balloon valvuloplasty apparently has been okay. We are going to advance now. The valve, I think, is almost prepared. We have been maybe too quick.
Fast, yeah. We have been hurried to be prepared at 12, and now we are too fast.
Vamos a poner la guía para allá y te cambio el sitio. Ponte para acá.
This valve uses 16 sheath, 16 non-expandable sheaths, so it needs 16 French sheath. The sheath that is usually with this valve is the Oscar sheath. It's a good sheath. It is not expandable, but I think that it's 16 French, but I think it's a good sheath with very hydrophilic. The minimum sizes for arteries is about 6 millimeters that is required, but this is sometimes very variable with according to the anatomy, to the calcium, etc.
Another thing to comment is that here we have the anesthesiology teams supporting us. This is not the usual thing in every center, but we have a very good relationship, and it's it's a relaxing thing for us because we are focusing the procedure, and the patient is so stable during it.
Yeah, these anesthesiologists are the same anesthesiologists that work with the cardiac surgeons, so they are accustomed to treat not only procedures with deep sedation, etc., but also patients with complex interventions, complex cardiac interventions, even emergencies, etc. So they are excellent, both professionally speaking and also from the personal point of view. They give us support every day, and we work very well with them. The valve is ready. Here we have Andrea and Lars Arnold from the biosensors company that they are today with us. Okay, this device is very soft. The advancement is very flexible. You are going to see how flexible it is without any problem advancing the valve through the aortic arc. Okay, we are now positioned here. Do you know, for example, that the Symetis valve, the accurate valve, expanded first at the proximal part of the valve? The core valve device first distally. In this case, the Allegra device first is expanded at the mid part. Vamos a ver el permaflow. This is called a permaflow because this allows that the valve is functioning since the first moments of the procedure. Test, por favor. These are radio pack markers are gold markers. How you can see that there is a radio pack line should be more or less at the level of the aortic annulus. We are retrieving the valve. Empuja un poquito la guía, si no. We are too high. If we are too high now, the last movement should be from the left ventricle to the aorta. So we have to go deeper and then go out again. So there is no good alignment of all the gold markers. So we try to go more caudal to align it. Okay, I think we are still too deep in the left ventricle. I think we have to go more proximal to the aorta. Dame un test, por favor. Pon marcapasos a 120, por favor. This valve doesn't need rapid pacing, but we are going to use 110, 120 pacing, or only to stabilize this, because the patient has with atrial fibrillation. Okay, I think we are here, okay? Cine. Estamos demasiado profundos todavía, ¿no? It's still 1-2 millimeters too deep. Demasiado alta ahora. A ver. Ahora. This. Cine.
¿Dónde estás, no?
Venga, a verlo.
Voy.
Sí. Ok, quita marcapasos. Sí. The valve has been open distally. Sí, sí.
Sí, tranquilo.
If we don't like the position, we could retrieve the valve and use it again. Vale, retírate si quieres. Ok. Vamos a hacer un... ¿Está retirado del todo? Sí, ¿no? Sí. Ok. Ok, voy a dejar ahí el píxel de momento. Vale, queda espacio.
The position is perfect.
Yeah, the position is perfect. Now we are going to open the most proximal part of the valve. Espera un poquito. Yeah.
And you can see the proximal part is deployed very slowly.
Yeah. Vamos a ver las test.
Voy a terminar ya.
Okay, now it is important to check that the T-bars there are 3 T-bars in the most proximal part. We see that 2 of them are free. The other one also is free, no? So we can retrieve the system. The pixel is still there. We have to retrieve. Okay, vamos a sacarlo si quieres. Vale, vamos a sacarlo si quieres. Despacito.
Cuidado que se mueve.
Despacito que se mueve. Se ha movido, no sé por qué. Vale, me empuja la guía. Vale. Queda un poco enrasada, ¿eh? Ok.
Dame un poquito de escopia.
Vale. Queda un poquito enrasada, tengo que haberle puesto. Sí, bueno, a ver, a mí yo estoy acojonado ya, macho.
Sí, no post-dilatación.
Vale. Bueno, vamos a poner
We are retrieving the system.
Sí, vamos a poner una angiografía, pone 10-25.
And check with the pigtail again the result.
Pone 25 de volumen, deja 15, que si no sé. 15.
Miren.
Oh, you can change the
There's
wire.
Important PVL, important regurgitation. We don't know if it is central or peripheral. The coronary artery are patent. Vamos a ir más caudales, a ver.
One option is to change with
Vamos
a
a hacer un
pigtail.
cine, a ver. Cine. Está muy justa ahí puesta, ¿eh? Uf, no me gustaría tener que postdilatarla. Vamos a cambiar por el pixel
a ver si mejora.
Es que esta se nos puede embolizar, ¿eh? Me da miedo, ¿no? Okay. We are going to interchange for the pigtail. Okay, the position is at the border of the annulus. This is to reduce the risk of pacemaker. Podría mostrar el eco, a lo mejor, ¿no?
Es el eco. Sometimes the Safari wire makes the regurgitation, so hope that after this change with the pigtail here.
Vamos a hacer otra inyección, a ver.
The arterial regurgitation improves a little bit.
This is still PDL.
Yeah.
So what to do? Post-dilate?
No, the debate is if we post-dilate for the regurgitation, as the valve is probably a little bit high, the risk of embolization is there. So this is the debate.
We are thinking about, theoretically, vamos a ver. This is the view that we had.
La de implante era 9 de
9, ¿no?
oblicuo izquierda y una de carne.
We can wait 5 minutes just to let the valve expand better.
Vamos a hacer un cine, por favor.
Do an echo. And then decide.
But the regurgitation is clearly severe. We have to post-dilate. Yeah. Okay, which balloon? Maybe 24? Or 24
Pre-dilation was 22, the previous one.
The previous one was 22, so we have to do. The balloon has been the 23, but what I think is that it was a 23 balloon, not a 22, but the balloon while being implanted, it was moving. So maybe this valve had a larger diameter than.
No, yo creo que cogería.
Unexpected.
Cogemos un Atlas de 24.
Venga, vamos a coger un Atlas de 24.
24.
Yeah, we are going to use an Atlas balloon of 24 balloon. We are waiting for your comments here.
I don't have any questions from the Slido app.
Vamos a ir metiendo la Safari en cuanto esté el balón, ¿vale?
La posición era buena. Sí, pero no estaba enganchada la T.
I have one question, Dr. Moreno, from Natalie. How did you ensure accurate placement of the Allegra valve during the procedure?
Yeah, the placement is with the line, that the radiopack lane that was. We can show you here. I don't know if you can see my finger here. This line should be at the border here. It was even 1 millimeter lower. So maybe that the valve finally was moved more proximally, 1, 2, 3 millimeters. We are afraid. So what we are thinking here that we are afraid of having a valve embolization during the post-dilatation now. And on the other hand, the valve is well expanded, so I am not sure. So we are also debating that the balloon that was used was a 23 balloon, and the balloon during the pre-dilatation was moving. So
you can show it.
Maybe that the aortic annulus was larger than initially thought. So here you can see how this is a 23 balloon that was inflated, fully inflated, but was moving during the inflation.
Probably it's bigger, yeah.
So maybe the aortic annulus is bigger than we thought. Maybe.
Even having analyzed it with CT scan and also with echo.
Yeah. So you see that say that we could do an echo here.
Yes, it's there.
We are doing an echo here.
I think
Yeah,
sí, podemos hacerlo ahora, ¿no?
sí,
Ya
podemos hacerlo.
esperamos.
Sí, we are going to wait.
Yeah. We're going to do an echo and leave the valve expand a little bit more.
Yeah. ¿Quién lo va a hacer?
Dani.
Dani, ¿no? Ah, vale. Daniel Tebar is going to
Tienes que mover el rayo, ¿eh?
do any calls.
Esperemos,
Así.
This is the debate. The patient had also a left anterior fascicular
es que
block,
meter la Safari, Raúl.
and
La Safari para sacar el
to
pigtail.
prevent
Sí. Ah,
advanced AV block, you
Déjame,
prefer a higher implant, but if you put the implant so high, the risk of embolization is still there. So
we're waiting for comments from some colleagues that could help us to make the best decision. ¿Cómo lo ves, Dani? Sí, pero ¿por qué se ha enganchado si las T's estaban libres?
Pues eso.
¿Eh?
No, eso, que no sé por qué.
Sí, por eso. Sí está. ¿Cómo lo ves, Dani?
I think you can see the echo, but Danny,
An important regurgitation, but the valve is well expanded, so I don't know because so maybe the valve that we needed was a larger valve.
no, the thing is that if we are
Because
going to
the
improve
valve-
it with post-dilatation or not.
Yeah, so the problem is that if we are going to reduce the post-dilatation, the regurgitation with post-dilatation or not, because the valve is well expanded. ¿Eh? Y la válvula está metida bien en el... Está... Muy alta. Tampoco en el tacto salida. So, we have to take a decision. Tenemos que decidir qué hacemos.
I think if you think that post-dilatation is going to improve it,
Yeah, that is the question, Alfonso. As Alfonso says, is so the first question we have to try to solve is why we have aortic regurgitation here, because the valve is high, but it is covering the aortic annulus theoretically, and the valve is very well expanded, but we have a pervalvular regurgitation. So maybe that the valve that we should have implanted was the 27 instead, the 31 instead of the 27, maybe. Eh? Yeah. Yeah. Okay, we have to post-dilate, no? Yeah, we have to post-dilate.
Let's go for it.
We have to post-dilate. We may have a valve embolization. We don't have to show you so interesting cases. We prefer to show you simple cases, but this is what we have now. So the risk we have here is to have an embolization.
Tenemos que preparar algo para la posible.
Sí, tenemos lazos
Hace
cerca.
falta un inflador.
Tenemos
para
lazos
eso,
cerca.
Con eso no se puede. Un manómetro. No, espera, que no tenemos fuerza para inflar ese balón.
Se puede cortar por abajo, sí. Other option, que se puede cortar por abajo la bola, claro. So the valve, when we were implanting the valve, the last step of the valve implantation, here the position was good. Now the valve is clearly higher, so the valve has moved during the retrievement of the system. This is regarding the position. And regarding the valvular regurgitation, we don't know exactly the reason. Maybe that being so...
¿No?
high position. Other option is to leave the patient and have check the clinical outcome, and according to the clinical outcome to
We're discussing also that the risk is not only the embolization, but also the valve could be shortened a little bit.
Yeah, embolization, I mean, by shortening the valve, and the valve.
Yeah. So this is the thing.
This patient is how old is?
Is 88.
Yeah, and it was a very severe aortic stenosis. No? It's another option. We could stop here. The hemodynamic situation is good, but no, we have to post-dilate.
Who knows?
Tenemos que post-dilatar, ¿no? No.
Venga, pues nada, adelante.
Venga. We're going to post-dilate.
Difficult decision, but we are going to post-dilate.
Necesitamos un manómetro. Espera, déjalo aquí fuera un momentito.
Sí, que nos falta manómetro.
We don't like the position. The position is too high at the end. And this is what is making us
lazos.
To have not very clear the decision we have to take.
Sí. Deja una jeringa de todas maneras aquí, pues hay que meterle un poco, pero...
So you see the position of the valve before here before the opening the proximal part, the position was 4 millimeters, 4 millimeters about 4 millimeters lower than the aortic annulus, and now once the valve has been implanted is only 1 millimeter or 2 millimeters below the annulus. And when we have a post-dilatation, the valve can be shortened distally, and we could have a valve embolization.
I have another question from the audience. How long does the balloon inflation need to be maintained during the procedure?
During post-dilatation?
I don't know.
For the pre-dilatation, until you see the balloon is opened, and here some seconds only. As in other valves.
Stopping the flow from the aortic valve, so just when you see the balloon well expanded, you deflate it.
Vale, suficiente. Gracias.
Bueno. And hypothetically, if we have a valve embolization, should we implant the same size of the valve, or should we implant a 31 valve? This is another important question. I hope not needing to take this decision today.
We have to have it in mind before this dilatation. ¿Tenéis aquí la 31 o no?
Bueno, vamos a ver.
¿Se marca?
El marcapasos tiene que funcionar bien.
Comprobarlo antes, si queréis, comprobarlo antes.
Sí, no, pero... Espera, no, ponlo cuando estemos ahí.
Más abajo.
Bueno, ponga 180, por favor. Venga, dale. Vale. ¿No quieres marca todavía, deshincha? Quita marca. The valve has been opened, I think.
Yeah.
Cuidado
careful with the balloon.
Ahora.
We have to be very careful now with the balloon.
Tira un poquito de la guía para que se separe de la válvula.
Sí.
Ahí.
Okay. Perfect. Tough moment.
Okay, let's check another angio.
¿Estamos para inyectar?
Sí, vamos a pasar el pigtail. Sí, vamos a pasar. Saca el balón. Let's check the post-dilatation here.
Yeah, you can compare the pre and post.
Yeah.
And it's obvious that the valve is more open.
Yeah. Or we want to think that it is more open. I think so, but
sometimes it's a desire, but now I think it's objective that it is better expanded.
We have been very careful. Okay, let's do the final angio. I hope the final angio.
Another question for you. Are there any immediate interventions that can be performed to retrieve the embolized valve?
Yes, I will tell you now. Dale.
Cine.
Much better.
Much better, much better, much better. Yes, we have implanted many of these valves. We have, of course, had some embolization, and we have been successful with snares, with 2 snares, using the T-bars that are in the most proximal part of the valve. And we have left the valve in the descending aorta. Do we have some cases?
Una guía amplas, por favor.
I think 2 cases. Okay, there is still some perivalvular leak, but of course now it's maybe great.
It's a great result.
Grade 2, no, more or less. Mm-hmm. Yeah. We can do the final angio at the right. We are going to do the final angio in this position in RAO to check the final result. Dale.
No, much better.
Mild PBL. Mild PBL. Okay, it has been an interesting moment for us, but you know that these decisions are in the daily
real life.
In the real life are very difficult to take. I think this is the most important advantage of having live cases, because this type of discussions are not shown if you see the a film case, for example. Okay, now what we are going to do now is to interchange the Safari wire by another wire to close the femoral artery with the manta.
Esta es la amplas, ¿verdad? Pues ya estamos.
Esta es la amplas.
Es una amplas, sí.
Okay, this is the amplas wire. This is not the Safari wire. So, perdón, Santi, ponte.
No, sigue. Hay que abrir a 5,5, ¿vale?
We are retrieving the introducer.
Are there more comments, Alfonso?
No.
No more comments?
Thank you, said Natalie.
Up. Okay, I think we are going to leave the pacemaker in the patient.
Yeah, the depth of the artery was
5.5.
5.5.
5.5, so we have to open at 7.
4.5.
Okay, so 4.5, and we have to open at 6?
No,
Yeah.
Between 5.5
and
between
yeah.
5.5 and 6. Hostia. Oh,
Sometimes the valve of
yeah, the valve of the
introducer
no,
is tricky.
yeah.
We can maintain the pacemaker because the patient has a left anterior fascicular block, and now I think the QRS is a little bit wide.
O sea, es 5,5, 6, ¿no?
Sí. Now Dr. Moreno is implanting the manta device, retrieving to achieve the depth that Dr. Jimenez Valero measured before. Okay.
Okay, now we have to wait about 1 minute here. Sometimes the company says 20, 30 seconds. We prefer to wait 1 minute.
Yeah. Dar la luz, por favor.
We promise you that the next Wednesday we are not going to implant another valve, only to show different cases. But
It was another device, I think.
It was another device, yes. I think there are two devices, the My valve the last week and today the Allegra valve, that are not the most widely valves that are used. So that is because of that we chose these cases to show you.
And every case has its tricky points, no? Like the case of today.
We have to tell you that we had today two Allegra cases. Theoretically, we chose the most complex one, the first case that we have done before this patient, and the result was excellent. And this case theoretically was easy, and that this is what happens with all type of procedures. Sometimes the case that you think is going to be easier, sometimes you have a complication, or not a complication, because we didn't have a complication, but some things that are interesting to be discussed.
You can see the image of the groin. There is no bleeding. We're going to check the position of the manta device from the contralateral axis.
Ali, el JR, ¿me lo dejas?
More comments here, Alfonso?
No.
No, we have been improved. The last day, only one question. Today, 3, 4.
3, you know, we
so next
have
week,
to thank to Natalie R. That is our follower.
Okay, as you are seeing, we are going to check by the contralateral, by the left femoral artery. We are going to check the status of the artery. You see that the radiopac marker from the manta is in the correct position. What we have to check now that there is no stenosis, bleeding, etc.
Another question from Natalie. What is the long-term prognosis for patients with aortic rehabilitation after valve replacement?
Well, good question. I don't have the exact answer, but if the prognosis, of course, if the PVL impact on the clinical outcome of the patients, of course, and how much. Okay, you can see here the result of excellent. Santiago says to do another view to check in the RAO to check exactly. So the prognosis of patients with parabolic leak after TAVI, of course, especially when there is a PVL grade 2 or larger, is worse, with a higher risk of rehospitalizations due to heart failure, higher mortality. That is the reason why it is better to have a good result as we had today. Of course, this was an 88-year-old patient, but it is not only the long-term follow-up, but also the functional class. Perfect. So in this case, if the valve would have been positioned in the deeper position, we wouldn't have discussed if doing a post-dilation or not. The reason, as you have seen, of discussing or not discussing, but about thinking about doing a post-dilation before doing it was because the valve was at the border that. On the other hand, this is the optimal position with many valves. So with the GADA view, etc., the objective is to position the valve as we have positioned it. But when you have and also an important PVL, sometimes you are always thinking about the risk of movement of the valve. We are going to use an 8 French angioseal for closing the left femoral artery. And with this, we are going to finish. Yeah,
if you don't have any other questions, I'm going to check the app. There's a congratulations from Natalie. So we are going to finish the connection, and we see you at 2 p.m. Spanish time for the next case of today. See you. Thank you.
Thank you.